Bueno, buenas tardes. Vamos a dar comienzo a esta charla del doctor Konishi. Los dejo con el doctor Cristian Rodríguez, quien los va a presentar y va a ser el encargado de manejar la mesa.
Bueno, buenas noches. Hoy contamos con la grata presencia de un prestigioso profesional como es el doctor Tsuyoshi Konishi. Él es profesor asociado del MD Anderson de Houston, con gran experiencia en este tema, con muchos trabajos publicados al respecto, y nos engalana esta noche. Y quería agradecerle personalmente que haya podido participar y explicarnos un poquito de qué se trata todo esto, de su gran experiencia. Doctor Konishi, sin más preámbulo, le doy la bienvenida y bueno, aguardamos su charla.
Hi, thank you everyone. Thank you, Christian, for kind introduction. Can you hear me? Can you hear me now?
Very well.
Okay, good. All right. So thank you. I'll share my screen, but today I'm gonna talk about one of the most recent, hottest recent topic, which is on the lateral lymph node dissection for rectal cancer. Thank you for providing me this opportunity to present my talk to the surgeons in the Argentine, which is my favorite country. And I will share, okay, starting from this slide. So now I think that you are looking at my title slide. Let me know if you have any problem. So first of all, I will talk about conventional viewpoint on lateral lymph node disease from the Western country. I have been working in Japan for like more than 20 years. After that, now I moved to the US. But for these 20 years, I have struggled when I make a discussion with Western surgeons from the US and Europe when we talk about this topic. Just because of a completely different viewpoint on this topic from the Western world. Number one, in the Western world, lateral nodal disease is considered to be systemic disease, not a regional disease. So it was far advanced and not a candidate for curative resection. And actually, another thought was they did chemoradiotherapy before rectal resection, and they believe chemoradiotherapy is sufficient to achieve 5 to 6% local recurrence in the rectal cancer. So almost there's no role for additional, pelvic surgery. And another thought, recently with the development of the total neoadjuvant therapy, we have even better response. So why do we need a lateral node dissection? It's a morbid procedure with a lot of complication, especially in the Western obese patient. So they just, believe that the lateral node dissection has a very little role on improving the outcome. And even when they need a lateral node dissection, they believe that we have urology and GYN surgeon, so they can do that instead of us. We will just call the urologist or gynecologist and just let them do the pelvic node dissection, so we don't have to learn it. And so I would challenge all these perspectives. First of all, this is the data from Dutch trial. That is a randomized trial of with or without radiation before the TME. It's one of the most famous game-changing randomized control trial. So when we see the outcome of local recurrence according to the height of the tumor, when the tumor is located high or mid-rectal cancer, there's a clear benefit of radiation to reduce the local recurrence. But for the low rectal cancer, within 5 centimeters from the anal verge, actually the adding radiation does not seem to reduce the local recurrence. And actually this low location of the tumor is an independent risk factor for local recurrence, regardless of with or without radiation. Why the radiation doesn't reduce local recurrence in low rectal cancer? it is clear, of course, this is multifactorial, but one of the major reasons is that the difference of the lymphatic spread. When the tumor is located above the peritoneal reflection, the tumor spreads solely within the mesorectum to the perpendicular, within the mesorectal lymphatic spread. So TME alone can control everything. But when the tumor is located below the peritoneal reflection, then tumor starts to spread not only within the mesorectum, but to the lateral area and developing the lateral local recurrence. So even with the radiation and the complete TME, because there's still a remnant residual disease on the lateral area, it cannot completely control the local recurrence. And this is very important. This data is coming from Japan, multi-center national data. So when the tumor is located above peritoneal reflection intraperitoneally, then almost there's no lateral node metastasis. But when the tumor is below the peritoneal reflection, that means, in other words, extraperitoneal tumor, then the tumor starts spreading to make lateral lymph node metastasis. And the incidence of lateral node metastasis is very minimal for the T1, T2 disease, but it's mainly for T3, T4 disease. So one important message is that lateral node metastasis is not for the tumor above the peritoneal reflection, not for T1, T2 disease. It is solely for the tumor, T3, T4 tumor below the peritoneal reflection. And when we focus on the tumor below the peritoneal reflection and the T3, T4 disease, multiple papers from Japan describe that the incidence of lateral pelvic lymph node metastasis is between 15 to 20%. And the incidence of the lateral lymph node metastasis becomes even higher when the tumor is lower located. As you see, when the tumor is located around within 2 centimeters from the anal verge, the ratio of the lateral lymph node metastasis is up to 40%. So you can, I think that you ever experienced, in an APR patient that require APR, it's a very low rectal cancer patient have a more frequent lateral lymph node recurrence. And so this is exactly the baseline data. When the tumor is located lower, you need to expect a higher lateral lymph node metastasis. And this is the multi-center data from Japan. Of course, this is a relatively old data set before 2011. And this data focuses on the patient undergoing surgery alone without chemoradiotherapy. So basically, they looked at the outcome according to the distribution of the lymph node metastasis. And actually, the internal iliac lymph node metastasis has similar outcome with the mesorectal N2 disease. And the obliterator lymph node metastasis is also similar to the resectable liver metastasis, like almost 40% survival. But when the lateral lymph node metastasis comes to external iliac or common iliac, then outcome is much worse, almost similar to our systemic disease. So one important message is when we talk about lateral lymph node metastasis, internal iliac and obliterator lymph nodes are the area that we are concerned. And these outcomes are similar to mesorectal or resectable liver mets. So it's considered to be regional disease. But when the lateral lymph node metastasis occurs in other areas like external iliac, then we should think that this is a distant metastasis. And this is the only randomized trial compared with and without lateral lymph node metastasis, lateral lymph node dissection were performed in Japan. So basically, this randomized trial is focusing on stage 2-3 low rectal cancer below the peritoneal reflection. And importantly, all the patients have negative lateral lymph node, clinically speaking, and no neoadjuvant therapy. Okay, but even without enlarged lateral node, they found 7% positive lateral pelvic lymph node in the pathology when they see when they focus on the pelvic lymph node arm. And if possible, could you delete this green line? I don't know how to do that, but when they focus on the outcome, the survival was the same between the two arms with and without lateral node dissection, but local recurrence was nicely reduced by adding lateral node dissection. There are two important messages in this data. Number one, in the TME alone arm on here, majority of the local recurrence occurred on the local in the lateral area, and which was nicely reduced by adding lateral lymph node dissection. So this represents how even in the clinically negative lateral lymph node patient, adding lateral lymph node dissection may reduce local recurrence. But in the Western world, they do chemoradiotherapy. So the next question is, does chemoradiotherapy control lateral nodal disease? Unfortunately, no. There are multiple data from Korea and also from the UK suggesting that if the patient has a baseline enlarged lateral lymph node with a chemoradiotherapy and TME alone, they have a very high local recurrence, up to 30% lateral local recurrence. And actually, according to the data from Korea, now in the era of a good chemoradiotherapy and TME, more than 80% of local recurrence now occurs in the lateral area. So that's why lateral lymph node dissection is very important. And this is the data from a systematic review focusing on the proportion of the residual lateral lymph node after chemoradiotherapy. And interestingly, in the responsive node, which means initially enlarged but shrunk after radiotherapy, still there's a residual lymph node metastasis up to 20%. And when the enlargement persists after radiotherapy, there's up to 80% residual lymph node, residual cancer in the lateral lymph node. So these data suggest even in the responsive node, there's a significant number of the residual lateral lymph node metastasis. And inconsistent with this data from Korea, they investigated on the outcome of T3, T4 mid-low rectal cancer. Importantly, this is below the peritoneal reflection, and all the patients underwent chemoradiotherapy plus TME without lateral lymph node dissection. And they classified the patient according to baseline normal lateral node and the initially enlarged but responsive lateral node and initially enlarged and the persistent lateral node after the therapy. And the local recurrence exceeded, from 3% for the normal patient to 10% for the responsive node and almost 30% to the persistent lateral lymph node. And I believe, this responsive lateral lymph node group with a 11% local recurrence is quite unneglectable. It's a significant high local recurrence. And so this data suggests even with a good response to radiotherapy, the TME alone cannot control the local recurrence. So far, this summarizing this data, lateral lymph node is now the major site of local recurrence after chemoradiotherapy plus TME, and actually the 80% of the local recurrence now occurs in the lateral area, like in this case. So what happens if we add lateral lymph node dissection to chemoradiotherapy? This is the data from my prior institution in Tokyo. So we make it a routine to give chemoradiotherapy for T3, T4 or node positive rectal cancer. And if the patient has a no enlarged lateral lymph node on the baseline MRI, we did only TME. But if the patient has 7 millimeter or larger baseline lateral lymph node, we added pelvic lymph node dissection. Actually, these are around 30% of the overall chemoradiotherapy patient. And interestingly, we found positive lateral lymph node around 60% of those undergoing lateral pelvic lymph node dissection. And different from the Korean data, which showed a high local recurrence with the TME alone, we achieved only 3% local recurrence, regardless of a lymph node positive or negative patient. And so this is the first data that showed a possible reduction of the local recurrence by adding lateral lymph node dissection in the patient with initially enlarged lateral node. And then now we extended this study to an international study involving 12 centers from 7 countries. So we collected the data, more than 1,200 patients with clinically T3, T4 rectal cancer within 8 centimeters from the anal verge. And we investigated on the outcome according to the predefined MRI protocol, and we measure the size of the lateral lymph node and look at the outcome according to the size of the lateral lymph node. And as you see in here, when the patient have 7 millimeter or larger baseline lateral lymph node, local recurrence in the lateral area comes to 20% of the patient who underwent radiotherapy plus TME alone. So this data again confirms that chemoradiotherapy plus TME alone do not eliminate local recurrence in the lateral area when the patient has initially enlarged lateral node. The other important aspect of this data is on the right side panel, rate of the distant recurrence or cancer-specific survival was the same, regardless of the size of the lateral lymph node. So again, lateral lymph node, in the Western world, it was a kind of a hypothesis that when the patient has a enlarged lateral lymph node, the patient has a higher risk for the distant met. But data clearly show there's no higher distant risk. Enlarged lateral lymph node is a regional disease. And when we compare the patient with and without lateral pelvic lymph node dissection to confining to the patient with a baseline enlarged lateral node of 7 millimeter or larger, then as you see in this in this figure, the patient without pelvic lymph node dissection has almost 25% overall local recurrence, and the majority occurred in the lateral area. But in the patient who received the lateral lymph node dissection, this local recurrence is nicely reduced to 66%. So this is the first large data set showing a possible contribution of adding lateral pelvic node dissection after chemoradiotherapy in patients with initially enlarged lateral lymph node. So what does enlarged lateral lymph node mean to us in the era of chemoradiotherapy? Number one, lateral nodal disease is not regional, is a regional, not a systemic disease in terms of prognosis. And it's a major cause of local recurrence in T3, T4 mid-low rectal cancer below peritoneal flexion. And surgery alone or chemoradiotherapy alone cannot fully control the disease. It's not mutually exclusive, but likely the combination of chemoradiotherapy plus selective lateral lymph node dissection for the patient with initially enlarged lateral lymph node may improve the outcome. So we should combine these two approaches. So, and the final question, does total neoadjuvant therapy eliminate the lateral nodal disease? Actually, there's no right answer for this. We are now considering lateral node study 2, international study in the era of TNT. But when we look at the Rapido trial data, this is a famous, a comparison of a short course radiation followed by Folfox versus conventional chemoradiotherapy. And as you see, as you know, PCR was almost double in the TNT approach, right? From 14% to 28%. But when we look at the YP node positive patient, it's almost the same, although it's statistically significant, but it's not double compared to the primary tumor complete response. Where the node positive patient, the reduction is very small. So this potentially suggests, in the node positive patient, the effect of TNT to eliminate the nodal disease may be not remarkable as the node negative patient. And this is the data from my prior institution investigating on the pathologic outcome after total neoadjuvant therapy. In this clinical trial, we did systemic chemotherapy, 3 months Folfox plus Bev, followed by chemoradiotherapy, then did a TME with a selective lateral lymph node dissection for the initially enlarged lateral node. So we involved a total of 76 patients, and actually 70% of the study population had enlarged lateral node. And actually, we achieved a complete response of almost 34%, which is very high response. But when we look at the pathology outcome, residual lateral pelvic lymph node metastases were present in almost 20% of the patient who underwent pelvic lymph node dissection. That means among the patient with initially enlarged lateral node. So this 20% is still high. So even with the TNT approach, we found a lot of residual lymph node in the lateral area. And importantly, the residual lymph node ratio is the same as a mesorectal residual lymph node. So if you do total mesorectal excision for primary rectal cancer, why not do lateral lymph node dissection for initially enlarged lateral pelvic lymph node patient? That is my message. And this data is another data set from MD Anderson. So basically, we looked at the data of clinically stage 2-3 rectal cancer with a baseline enlarged lateral node involving around 150 patients. So we performed almost pelvic node dissection for 56% of the patient. In the US, we didn't stick to the baseline criteria, but more likely with a persistent lateral lymph node patient. But when we look at this entire baseline enlarged lateral lymph node patient, quite similarly to my data from Tokyo, we found residual lateral pelvic lymph node in 20% of the patient, which was around almost 1/3 of the patient who underwent pelvic node dissection. And importantly, there is no increase of a distant or local recurrence than TME alone. So again, by adding lateral lymph node dissection, we achieved a very good local recurrence, and distant metastasis was again the same. So that means this disease is regional and not a distant disease. Currently, there are multiple clinical trials or clinical studies, prospective studies ongoing. One is a nominate study in the Tokyo. The other was an ensemble study in the entire Japan, comparing regular chemoradiotherapy versus TNT approach, or no, this is a consolidation versus induction chemotherapy. And ensemble is a comparison of a consolidation Capox versus Capoxy. But in these two approaches, they incorporated the lateral lymph node dissection for the initially enlarged lateral node. So these data will provide some additional data on the role of a lateral lymph node dissection in the era of TNT. So next discussion is who should do this lateral lymph node dissection? Look at this distribution of anatomical distribution of a positive lateral lymph node. In the rectal cancer, mainly the lateral lymph node metastasis occurs in the obturator or internal iliac area. But when we compare to the distribution in the urology cancer or GYN cancer, as you see in the GYN or urology, the pelvic lymph node metastasis occurs in more superficial and the external iliac area, mainly external iliac and superficial obturator area. And this deep area, deep obturator and the deep internal iliac area are kind of neglected in the urology or GYN patient. So this is why we should not rely on the urologist or gynecologist to do this procedure. When we ask this procedure to them, they wouldn't take this most important deep area, which constitutes actually 50% of the lateral lymph node metastasis, according to the Japanese data. And why this happens? It's very simple. In rectal cancer, the lymphatic spread comes along the middle rectal artery. But as you see on this slide, middle rectal artery have a lot of variation, mainly coming from the inferior vesical artery. And according to the where the middle rectal artery bifurcates, the lymphatic spread travel along the inferior vesical vessel and coming to the internal iliac area. So that's why it's located in a very deep area, as you see on this MRI slide, in the deep area just besides the obturator internus muscle or just at the exit of the internal iliac artery to the pudendal canal. So again, this deep area is the most important. And this is the data from my prior institution. We investigated on how often this most distal area carries the lateral lymph node metastasis. And actually, 44% of lateral lymph node metastasis occurred in this distal compartment. But importantly, when we do appropriate lymph node dissection, this distal lateral pelvic node positive patients have even better prognosis compared to proximal lateral lymph node metastasis, just because these are the sentinel lymph node. It's the first coming place. So it is important to make sure to dissect this deepest area. Currently, we are holding multiple cadaver sessions and video sessions in everywhere in the, including Korea, Brazil, Canada, UK, recently Netherlands, Russia. And also there are a lot of video publication with my good friend from Brazil, Rodrigo Perez. And we are working on distributing this lateral lymph node dissection minimally invasively. And we got a couple of awards from ASCRS as well. So you can take a look at this video publication to learn this procedure. Okay, so finally, I will move on to some technical aspect of this procedure. So there are so many, complex anatomical landmarks, and it is very difficult to understand the anatomy. That's why this procedure looks like very difficult. But in order to understand the procedure, we can just understand only 3 planes or 4 planes on the lateral compartment. Okay, so this is the right side right side lateral pelvis. Number 1 is the parietal pelvic muscle plane, composed by psoas muscle and obturator internus muscle. The muscle plane, pelvic muscle plane. This is the first plane. Second plane is the urinary bladder and the pelvic plexus. the autonomic nerve. This medial plane, or in other words, called ureterohypogastric fascia, but then this name is not important. Just think that this is a medial plane composed by nerve and the urinary bladder. And the third plane is the dorsal plane, posterior plane, made by internal iliac vessel and the sciatic nerve. So these three planes compose the lateral area. So basically, the area surrounded by these three planes are to be resected in the lateral lymph node dissection. And there's another plane that divide this area, which is called vesical hypogastric fascia. And the vesical is a bladder. Hypogastric means internal iliac in the classic anatomical name. In the ancient, in the very old time, internal iliac area was called hypogastric artery. So vesical hypogastric means urinary bladder to internal iliac, combining these two structures on this dot line. And the medial to this vesical hypogastric fascia is the internal iliac area. And the lateral to this plane is the obturator area in this screen. So basically, this vesical hypogastric fascia divide the area into internal iliac and the obturator areas. What is vesical hypogastric fascia? This is actually, right lateral to the umbilical artery. You see the umbilical artery in here, and now I am incising just lateral to the umbilical artery, and you see clear embryonic plane between the lymphatic tissue and the bladder tissue, right? So now I am dissecting the obturator lymph node, dissecting it from the bladder tissue. And then now we reach to the pelvic floor, and I'm separating the distal obturator lymph node from the umbilical artery. This is a completion of the procedure, but basically by following this vesical hypogastric fascia, we can separate the obturator lymph node from the bladder tissue. Okay, so I will skip this video, but just in a straightforward case, when the enlarged lymph node is located in this lateral compartment, lateral to this vesical hypogastric fascia, we can do obturator lymph node dissection and internal iliac dissection separately, preserving all these umbilical artery and the inferior vesical vessels, just following the vesical hypogastric fascia. But in many cases, enlarged lateral pelvic lymph node involves the vesical vessel. On this occasion, we need an unblock resection of the vesical vessels. So it is important to evaluate the MRI, and according to the anatomical location, we need to customize the dissection. So I will show you one video. This is quite a typical case. There's a chunky lymph node in the just besides the obturator internus muscle, and the node involves a couple of vesical artery. So I did a pelvic lymph node dissection with a combined resection of the internal iliac artery. So first step is to isolate the ureter. Now you see I'm trying to separate the ureter and the pelvic nerve in order to preserve these structures. Then now the adnexa is lifted up to keep the pelvic, keep the view. The first step, I'm trying to identify the psoas muscle right behind the external iliac vein. Now you see lymphatic channel communicating from the obturator lymph node to the inguinal canal. So this is to be clipped in order to avoid the lymphoria. Then now you see I identify the psoas muscle right behind the external iliac vein. And first step is anteriorly identify the obturator nerve entry point into the obturator foramen. If you follow the pelvic muscle, you can easily identify this entry point, which is obturator canal. And now obturator vessels are ligated. And dissection further follows on the muscle to reach the pelvic floor. Now you see the levator there's a attachment of the levator to the obturator internus muscle, which is called tendinous arch, this whitish tendon. And now we communicate it to the TME space on the left side. Now you see the levator ani muscle beneath the tendinous arch. So this is attachment of the levator muscle to the obturator internus muscle. This is the end. Then obturator nerve is isolated. And then dissection move on to exposing the internal iliac artery and the umbilical artery. Then proximally, the proximal part of the obturator lymph node is ligated. Then dissection further exposes each branch umbilical artery, internal pudendal artery, and then now because this case needs a combined resection of the internal iliac artery, I'm trying to encircle the arteries. Now the umbilical artery is ligated, and the main trunk of the internal iliac artery, which is an internal pudendal artery, is ligated. Then laterally, now I am exposing the sciatic nerve. This composes the dorsal plane, posterior plane, as I explained previously. Basically, the dissection follow on the surface of the sciatic nerve, and medially, you nicely see the surface of the internal iliac vein. And this is the branching point of the obturator vein, which is involved by the tumor. So now I am encircling and dividing the obturator vein. And dissection further follows on the surface of the main trunk of the internal iliac vein. And now this is a re-entry point of internal pudendal artery into the pudendal canal, which is now ligated again. Now the pudendal artery is ligated. Now then, so the lymphatic, the dissection finally move on to the vesical hypogastric fascia. Now the umbilical artery, distal part of the umbilical artery is ligated, and dissection follows on the embryonic plane between the bladder and the obturator lymph node, as I showed previously. And dissection move on, and vesical arteries are all ligated with the internal iliac artery. So again, divided at the entry point into the bladder. Vesical vessels running into the bladder. So if we follow the vesical hypogastric fascia, we can easily identify the entry point of the vesical artery. You see a chunky lymph node just below there. So I'm trying to make sure enough margin from the lymph node, so making division of the inferior vesical vessel at the entry point into the bladder, and now the specimen was taken in an unblocked fashion. This is the completion. So you see all the structures. Now artery is divided in a combined fashion, exposing a sciatic nerve, internal iliac vein on the posterior side, pelvic muscle on the as a lateral plane, and medially pelvic nerve is preserved. So in this patient, nerve was completely preserved, so the patient preserved a very nice urinary function. How about the complication? In the era of open surgery, this is a result of a randomized trial in Japan. Even without chemoradiotherapy, there's a significant increase of grade 3/4 complication compared to 16% in the TME alone. There was a 22%, almost 1.5 times higher complication in the pelvic lymph node arm. And mainly, the complication was actually the complication itself. When we look at the detail of the complication, there's not a significant increase. Only bleeding was increasing. So bleeding was the issue in the era of open surgery. And now, in the era of minimally invasive surgery, when we do a separate case match study, in the comparing the laparoscopic versus open lateral lymph node dissection, laparoscopic approach nicely reduced the bleeding amount. with the open, the median is like 700, which is a significant bleeding. And now in the era of minimally invasive, this is much lower with a reduced blood transfusion. And how is the outcome in the more experienced center? This is the data from MD Anderson. We investigated on the robotic pelvic lymph node dissection, and actually the bleeding amount was 150, and the grade 3 complication occurred in only 10%, which is quite similar to my prior institution to Tokyo. I mainly did a laparoscopic approach in this time period. Now I do everything with the robot, and previously I did with the laparoscopic. And more than 100 cases, then bleeding amount was like 115, and the grade 3-4 complication was again around 9%. So after the learning curve, you can reduce the grade 3 complication from 23% to 10% at the end of the road with a minimally invasive approach. So this is the summary of today's talk. Lateral lymph node disease is a curable disease with TNT plus selective pelvic node dissection. Pelvic node dissection likely improves the outcome, mainly reducing the local recurrence and in the selected patient, which is an enlarged pelvic lymph node group. And the proper indication is crucial to reduce the unnecessary complication. So that needs further studies. Maybe we need a lateral node consortium 2 study in the era of total neoadjuvant therapy. And obviously there are many challenges and limitations because, majority of the evidence is still retrospective. And there are quite limited proctors of this procedure outside of Japan and Korea. So we are trying to hold a periodical cadaver training course in the US as well as in the Latin America as well, hosted by Rodrigo. So hopefully, actually this year at the American Society of Colorectal Surgery, ASCRS next month, we are holding the first didactic course of lateral lymph node dissection hosted by ASCRS. So if you are interested in, please contact to the Medtronic. Maybe they will offer some available slot for you. So thank you for your attention. Happy to take the question.
Bueno, muchas gracias, doctor Konishi. La verdad que muy didáctica, muy concisa, muy pedagógica, así que le agradecemos mucho. Ahora, si nos permite, voy a dar presentación a nuestros comentadores. En el día de hoy tenemos al doctor Fabio Leiro, él es presidente de la Academia Argentina de Cirugía, es presidente de la Sociedad Argentina de Coloproctología, bueno, conocido por todos nosotros, así que Fabio, si querés hacer algún comentario o alguna pregunta, te damos la palabra.
Hola, bueno, ¿se escucha?
Sí, perfecto.
Bueno,
Yes.
buenas tardes a todos. En primer lugar quiero pedir disculpas porque estaba con una cirugía, una exenteración pelviana y se me hizo un poquito tarde y lamentablemente me perdí una parte de la charla del doctor Konishi. Si bien es muy conocido su experiencia, la verdad que me siento un poco incómodo de tener que comentar una charla de la cual me perdí una parte y vuelvo a pedir disculpas por eso porque, bueno, ustedes son todos cirujanos y sabrán entender que a veces las cosas no inician en el horario que uno cree e incluso pueden demorarse más de lo que uno pensaba. Pero sí, algunos comentarios que me parece interesante. Está claro que cada vez menos dudamos en Occidente que los ganglios laterales existen, que no son enfermedad metastásica, que no implican el mismo pronóstico que la enfermedad metastásica, y que cuando se los logra controlar, esto correlaciona con una clara mejora en la sobrevida y una clara mejora en las recaídas locales. El punto es, digamos, cuál es el mejor método para controlarlos. Digamos, todos también conocen que yo hace casi ya 20 años tuve la oportunidad de estar en el National Cancer Center Hospital con el doctor Morilla en Tokio, y cuando volví a la Argentina vine muy entusiasmado con las linfadenectomías laterales y empecé a hacer mi experiencia. Acá todo el mundo me miraba como que estaba un poco loco haciendo eso, todavía no se había publicado el trabajo de Fujita, de donde es el estudio prospectivo y randomizado, y en Japón lo hacían de manera prácticamente sistemática. Y la verdad que mi experiencia acá fue bastante desoladora porque hice muchas linfadenectomías, así, digamos, cirugía abierta, con unas linfadenectomías realmente muy amplias, donde dejaba prácticamente todo el espacio, toda esa zona completamente disecada y limpia de tejido adiposo y de ganglios, y la mayoría, prácticamente el 90% de las veces o más, los ganglios eran todos negativos. Cuando empezó la radioterapia, esto, digo, bueno, va a ser peor aún. Seguía haciendo algunas de manera más selectiva y también eran negativos los ganglios, con lo cual hoy creo que la discusión pasa por cuál es el paciente que se beneficia con esto. Un poco el doctor Konishi lo anticipó, y ahí apunta mi pregunta, ¿no? Exactamente cuál sería para él la indicación, si el ganglio ha aumentado de tamaño, si el ganglio ha aumentado de tamaño que no responde a la quimioradioterapia, o el ganglio aumentado de tamaño que no responde, si tenía un determinado tamaño, también lo considera indicación de hacer linfadenectomía lateral. Así que un poquitito esa sería mi primera pregunta. Y la segunda, yo que tuve la oportunidad de hacer muchas linfadenectomías a cielo abierto, cuando empecé a hacerlas por vía laparoscópica, obviamente, si bien la diferencia en sangrado es significativa estadísticamente, pero clínicamente tampoco es muy significativa, porque perder 300 o 400 o 500 mililitros quizá digamos, no cambia el pronóstico o la evolución del enfermo. Y también hay que tener en cuenta que obviamente los pacientes con ganglios laterales positivos son pacientes que tienen quizá una enfermedad más avanzada, y eso también puede influir a que tengan más sangrado, no solamente la linfadenectomía. Pero sí es cierto que la laparoscopía mejora mucho la visión, da más seguridad, y bueno, un poco él ya lo anticipó, pero creo que seguramente la cirugía robótica también va a contribuir a mejorar esto. Es verdad así que quería un comentario en ese sentido, el que hizo los dos caminos, y también, ¿no?, coincido con él que es muy difícil imponer un método en Occidente del cual hay muy pocos especialistas que tienen verdadera experiencia y que pueden transmitirla y pueden convencer, al estar ellos mismos convencidos, que esto puede tener una indicación. Más difícil aún es cuando digamos, el porcentaje de pacientes que tienen ganglios, no responden a la quimioterapia y se van a beneficiar es realmente bajo. Así que bueno, un poquito estos eran mis preguntas y comentarios, y agradezco a la Sociedad de Coloproctología, a vos, Cristian, por la invitación, y vuelvo a pedir disculpas.
Okay, thank you for really wonderful questions. I think the first question was on the indication who benefit from lateral lymph node dissection, correct? Yes. So I would just just repeat this key slide. Number one, when we see the local recurrence according to the size of a lateral lymph node, when the patient have enlarged lateral lymph node on the baseline MRI before the treatment, TME never controls the local recurrence, mainly in the lateral area. This is confirmed by the data from lateral consortium. As I think that you already read this paper, many of you. But when the patient have a 7 millimeter or larger lateral lymph node, there's a significant high risk of the local recurrence, up to 20%, which is not acceptable. And important other aspect is actually, although this paper is not famous, this data from Korea is very important. This represents quite a solid number. What happens if we do only TME without lateral lymph node dissection? Actually, this is from the National Cancer Center in Korea. In this era, before 2016, they didn't do lateral lymph node dissection, believing that chemoradiotherapy can control the local control. But when the lateral lymph node is normal, that's true. You know, without enlargement, TME alone can control all the local recurrence. But when even in the responsive node, and no doubt, when the patient has a persistently unresponsive lateral lymph node, there's a high local recurrence, up to 30%, which is quite consistent in the multiple literatures. But more importantly, even in the responsive lateral lymph node, initially enlarged but nicely shrunk less than 5 millimeter after the treatment, but still there's a 11% lateral lymph node recurrence. And you know, it's up to, you know, the skill set, you know, whether you consider this 11% is acceptable or not. But generally speaking, in the era of, you know, neoadjuvant therapy, more than 10% local recurrence is very high. And this actually the responsive lateral lymph node patient are real good candidate because persistent node is a kind of bad biology and it has a higher distant mets as well, actually, honestly speaking. But these responsive lateral lymph node patients really survives by surgical resection. So answering to your question, I would favor to based on indication based on initial enlargement, regardless of the response. Even for the responsive lateral lymph node, I would favor to give lateral lymph node dissection. But you know, this is something but still debatable. I understand in the Western world, you know, now the surgeons agreed upon doing lateral lymph node dissection for the persistent lateral lymph node, but they tend to omit lateral lymph node dissection for the responsive node. And this is something, you know, maybe also it's not, you know, simple, right? It's multifactorial. If the primary tumor achieves a complete response, then I agree, you know, the responsive node should be also, you know, negative. But if there's a persistent incomplete response in the primary tumor, then we should consider even in the responsive node could be still positive, right? Likewise, the mesorectal lymph node. So that is something I take into account in the determining the indication. And for your second question, obviously the robotic approach is quite ideal, not only doing this complete procedure, but to share the technical procedure. This is in terms of the surgical education. The problem with the open procedure is we cannot share the procedure, right? We can learn only in the OR. But for the minimally invasive approach, we can learn from the video, a lot of things, because, you know, everything is anatomy, not the technique itself. Everyone in the world is now a very good surgeon, minimally invasive surgeon. They can do TME with a robot, at least. But they cannot do lateral lymph node dissection just because they are not familiar with the anatomy. And that is something that minimally invasive approach can contribute. Everyone can learn exact anatomy. What is the bleeding point? Where is the layer to go, right? And as I showed in the video. So that is something that I can emphasize. You know, I would recommend the robotic approach. So if I do patient after major surgery, if I see a lot of adhesion, I do adhesion lysis with open approach. Then I close the open incision and I do the pelvic procedure with a robot. That's how I do, because I want to reduce the bleeding. By reducing the venous bleeding with a pneumoperitoneum, we can see clear anatomy on the pelvic sidewall. If we do with this open, without pneumoperitoneum, there's a lot of oozing from the vein, and that messes up the anatomical understanding. I might be a little bit too much, you know, on the minimally invasive side, but I really feel the strengths of the minimally invasive approach under the pneumoperitoneum.
Muchas gracias. Thank you.
Bueno, muchas gracias, Fabio, por los comentarios. Doy paso entonces a nuestro segundo comentador, que es el doctor Adrián Matacheo, el jefe de la sección de cirugía colorectal del Hospital Ramos Mejía. Adri, por favor.
Muchas gracias. Gracias por la invitación. Paso rápido a tres cuestiones puntuales. La primera es felicitarte rápidamente, Cristian, y esto es de verdad, más allá de las palabras, estas charlas elevan mucho la vara para la sociedad, para nuestra formación como cirujanos y como cirujanos colorectales por la calidad de la presentación y del presentador, y no son palabras vacías. La segunda es una consideración a partir de lo que tanto el doctor Konishi y Rodrigo, en nuestro medio, Rodrigo Pérez, en nuestro medio y en nuestro país, están difundiendo, y que a mí me hacen pensar cada vez que formo parte de alguna o de algún curso, ya sea para aprender a realizar la técnica o de charlas teóricas, es que cada vez me convenzo más de que es una cirugía que tenemos que tener los cirujanos que operamos cáncer de recto en el radar, que saber hacerlas, y siendo una cirugía que no se hace frecuentemente, tenemos que reforzar los mecanismos para hacerla, justamente, y aprender a hacerla, porque si no la hacemos nosotros, me sigo convenciendo de quién la va a hacer. Y resumo con 3 preguntas cortitas también para el doctor Konishi, que me surgieron a partir de su presentación, que tienen que ver con, en principio, una cuestión más bien teórica y otras 2 más técnicas. Él mencionó en unos trabajos prospectivos de los cuales es parte, que involucran el TNT y además la linfadenectomía. Todos estos estudios usan la inducción y no la consolidación, y le quería preguntar si esto tiene que ver con la linfadenectomía, o mejor dicho, con la diseminación hacia el espacio lateral, o están más relacionadas con conceptos generales, una elección de la inducción para el TNT. Y decía, después 2 preguntas un poquito más técnicas. Él es tal vez por lo menos a mi entendimiento, uno de los pocos cirujanos que tuvo experiencia operando pacientes japoneses, de los cuales todos sabemos y decimos de hace mucho tiempo, en Occidente son diferentes porque son más flacos y de contextura más pequeña en general, operando los norteamericanos obesos. Si técnicamente encontró diferencias en términos de complicaciones, si tuvo más dificultad, más tiempo operatorio, más sangrado o no encontró ninguna diferencia. Y si usó o cree que la fluorescencia puede ayudar, también boga también en estos días, puede ayudar a identificar más ganglios, o es algo prescindible a la hora de hacer esta cirugía. Gracias.
Okay, starting from your second question, first of all, I'm now working in Texas, which is the most obese state in the U.S. And I operate on a lot of obese patients, which is maybe double of a Japanese patient, like most of the case. But honestly speaking, the TME is very difficult with a narrower pelvis, a lot of fat, mesorectum. But on the lateral area, almost the same. Lateral area obesity doesn't matter. And also, the data from MD Anderson, as I showed in the paper, the complication rate or bleeding amount is completely the same as what we had in Japan. So basically, the lateral lymph node dissection itself is not really difficult in obese patient in our experiences. Yeah, TME is more problem in my opinion. And the second, actually, what was your first question? Sorry, can you just what was your?
¿Por qué la elección de la induction chemotherapy instead of consolidation chemotherapy in TNT?
Okay, yeah. So that was actually a very old study around 2013 to 2017. In that era, there's no OPERA trial. So, still there, even at MSK, they are doing a lot of induction chemotherapy. So that was the data. And now we are doing, next study comparing induction versus consolidation with a selective lateral lymph node dissection in my prior institution. Yeah. But honestly, the data, I mean, regardless of a consolidation or induction or whatever, we are not looking at the patient who achieved the complete response. We are looking at the, patient who did not achieve complete response, right? When we operate on the patient. So now in the era of watch and wait. So if the patient achieve a complete response, regardless of consolidation or induction, maybe we can safely do watch and wait. But if the patient has an incomplete response, then that's the time that we need to consider, adding lateral dissection when the patient has initial baseline and large lateral node. That's my currently practice.
Y la última era la fluorescencia.
Ah.
Fluorescence image.
Yeah, fluorescence. So I agree. I was trying to utilize ICG in some cases, but answering your question, I don't think that the ICG helps, just because rather my dissect, because as I showed in my presentation, the deepest part is the most important. And in order to take the deepest part, anyway, we need to take this lateral compartment as using all the plane and do the entire lateral lymph node dissection, not the apple picking. So regardless of ICG illuminate the lymph node or not, we need to expose all these structures and take out all the lymph node. And actually, so if the ICG is may be useful only when we do like a sentinel lymph node, right? Likewise in other breast cancer or whatever. But on the lateral lymph node, there's no concept of sentinel node so far. So for example, Dr. Choi from Korea likes to use ICG in order to make sure there's no residual lymph node. But in my practice, I don't routinely use the ICG, and because it doesn't change anything. Anyway, we need to resect the entire compartment. So yeah.
Thank you very much, Tsuyoshi.
Yeah, my pleasure. Thank you.
Bueno, gracias Adrián por el comentario. Vamos a dar paso al tercer y último comentador. El doctor Julio Lococo es el encargado del sector de oncología, de coloproctología del Hospital Churruca. Julio.
Sí, ¿se escucha bien? Cristian.
Sí, hace un poco de eco, pero bien.
Bueno, perfecto. Hago extensivo mis felicitaciones al doctor Konishi por la calidad de la presentación, obviamente, ya que eso nos permite a todos aprender un poco más sobre el compartimento lateral y la enfermedad ganglionar del cáncer de recto. Y me estuve el tiempo, voy a tratar de ser lo más conciso posible. He visto en su presentación que la diferencia de complicaciones es casi similar cuando uno realiza la cirugía por vía laparoscópica o por vía robótica, y quisiera saber él cómo se sintió al comenzar a realizar la cirugía robótica y dónde le ve la mayor ventaja para realizar la disección lateral. Y otra pregunta que le quería hacer es si él le da una gran importancia a la primera resonancia previo al tratamiento, si tiene ganglios que están en el límite entre 6 y 7, y después realiza el tratamiento de quimioterapia, y eventualmente esos ganglios decrecen en su tamaño significativamente o incluso desaparecen. De esa manera lleva igual a la linfadenectomía o todavía se mantiene expectante.
Okay, thank you for the question. So for the first question, sorry, the first question was sorry, can you remind me the first question? Sorry, yeah.
Sí, ¿cuál era la ventaja?
Advantage.
Comienzo la utilización de la.
Right. Advantage of the robot. Yeah. Okay. So there are pros and cons of the robot. Obviously, the robotic has an easier manipulation. Especially, there are a lot of tiny vessels in that area, and robotic has a very good, energy device and the meticulous scissors to for the dissection. So technically speaking, even with an unexperienced assistant, we can do this complex procedure with a kind of a solo surgery. In the laparoscopy, you need a very good experienced assistant. In the robot, you can do by yourself. But there's a limitation of the robot. That is a suction. Actually, you know, in the laparoscopic procedure, we can freely use the suction, and that area gives a lot of discharge during the procedure. That makes procedure sometimes very difficult. So we need a really good suction. But with a robot, we don't really have a good suction system, right? We need to depend on the assistant. So on that situation, I usually put a soft tube with a connected to the continuous suction and try to manipulate that by myself, because sometimes, or even actually in many cases, assistant have some difficulty to freely manipulate the suction tube, right? So that is something that you need to consider, how to use the suction in the robotic procedure. But otherwise, manipulation itself, robotic has quite a big advantage. And your second question, what I do for the shrunken node after the radiotherapy, correct? Responsive node.
Exacto.
Yeah.
Incluso casi desaparece. En el caso que desaparezca incluso.
So basically, I do lateral lymph node dissection regardless of the response. Even in the responsive lymph node, I will do that, because if we don't do that, according to the data, there's 11% lateral lymph node local recurrence. 11 is not very high, but not very low. And actually, these patients, responsive nodes are really good candidate for resection, because we can expect a very good outcome. But when the patient has complete response in the primary tumor and with a very good response in the lateral lymph node, then maybe I would consider watch and wait. Yeah. So when we consider watch and wait without surgery for the primary tumor, I would leave it in the lymph node as well. But if I do consider TME, then I would consider lateral lymph node dissection based on the baseline size rather than the post-treatment size. But that is something we need more studies, which is better.
Ante una adenopatía bilateral que compromete los vasos vesicales, ¿cómo se maneja ante ese paciente?
Oh, yeah, that's an important question. So, so I think you are worrying about, losing the blood flow when the patient has a bilateral lateral lymph node affecting or involving the vesical vessel. So in most of the case, the involved vesical vessels are inferior vesical vessels, okay, not a superior vesical vessel. So there are 4 systems in the human body. Superior vesical artery coming from around umbilical artery, and inferior vesical artery, which is coming from very distal. And because of the location of lateral lymph node, which usually occurs in very distal part, most of the case, the lymph node involves the only inferior vesical vessel. So you can safely take bilateral inferior vesical vessels still, but make sure to preserve superior vesical vessel, at least in one unilaterally. So for example, when I had a very advanced case, I do complete resection of the left side, taking all the artery involving the superior and inferior vesical artery. On the right side also, I took out inferior vesical artery, but preserving only right side superior vesical artery coming from the umbilical artery. Then the patient bladder can survive without any problem. So just, the point is, in most of the case, you can preserve superior vesical artery, or you should try that. But inferior vesical artery is often involved, so you can safely take it on condition that superior vesical artery is preserved.
Ok. Voy a hacer la pregunta en inglés, la pregunta previa en inglés. If you have a complete clinical response for 5, 6 years, and then you have a recurrence in the lateral node, you perform only TME or only or TME plus resection of the lateral node? Or just resection of the lateral node without TME, sorry.
Yeah, actually, because we are doing a lot, we are treating a lot of rectal cancer at MD Anderson, or actually we have already a couple of cases with persistent lateral lymph node with a complete response in the primary tumor. And on that case, or in some cases, the patient develop only recurrence on the lateral area without developing on the primary tumor recurrence, regrowth. On that case, I do only lateral lymph node without primary tumor. And this happens just because of different dose of radiation in the primary tumor and the lateral area, right? Because in the most of the case, the primary tumor received boosting, right? 55 plus alpha, like a 5 or 6, right? Totally 650 gray in the primary tumor. But in the lateral area, depending on the institutional protocol, but in many institutions, still lateral area receive only 45. And the distribution of the radiation is not the same on the entire pelvis, unless you are doing a IMRT. So sometimes it happens, lateral area has a persistent disease with complete response in the primary tumor. And on that case, I do only lateral lymph node dissection without TME. And that is a really great surgery. The patient keep very good functional outcome in the anus. And because we don't do TME, actually, I did a couple, actually multiple cases, like maybe 5 or 6 only lateral lymph node dissection, but all of them achieved a very good functional outcome, not only, anal function, but sexual and urinary function as well.
Muy bien, bueno, muchas gracias, doctor Konishi. ¿Alguna última pregunta? Pues estamos cortos de tiempo ya y no queremos abusar del tiempo del doctor. ¿Alguien más? Bueno, entonces sin más preguntas, doctor Konishi, de parte de la Sociedad Argentina de Coloproctología, de todos los conectados que estamos acá, miembros, queremos darle muchas gracias por su tiempo, por compartir esta charla con nosotros y bueno, esperamos poder contar con usted en algún otro momento, quizás por Zoom o en forma presencial.
Thank you very much for having me. Bye, everyone.
Gracias. Muchas gracias.
Thank you.
Bueno, para el resto de los socios les comentamos que tenemos un caso clínico, así que nos gustaría que se queden conectados. Así que, doctor Tinguitera, le doy paso a usted para el siguiente caso. Guillermo.
Se le cortó.
Muchas gracias. Doctora
Ahí
Sasha Reiderman,
Ahí está.
presidente del hospital, va a presentar sus... ¿Se escuchan? Adelante, Sasha, tu caso.
Hola, doctor, buenas noches. Ahí comparto la pantalla. Bien. No sé si ahí la pueden ver.
Sí, perfecto.
Bueno, buenas noches, ¿cómo están? Mi nombre es Sasha Reiderman, soy residente de coloproctología del Hospital Británico y trajimos para presentarles un caso que fue tratado en nuestro servicio. Vamos a presentar una paciente femenina de 35 años de edad que fue diagnosticada con enfermedad de Crohn a los 25 años. Ella realizó inicialmente tratamiento solo con prednisona, tuvo una recaída endoscópica de la enfermedad, por lo que se optimizó en su momento tratamiento con azatioprina, y tuvo una buena evolución, de forma favorable, logró suspender la corticoterapia, y a los 29 años cursó un embarazo, el mismo fue saludable. Al término del mismo, ella decide suspender la cetiopría y abandona el seguimiento por nuestro equipo. Vuelve a consultar luego de 6 años de no haber sido evaluada por ningún especialista, por dolor abdominal. El mismo era predominio de fosa ilíaca derecha, era leve y persistente, se asociaba a alteración del ritmo evacuatorio, presentaba en el momento entre 4 y 5 episodios de diarrea por día, alternando con algunos días de constipación. También refería molestias en la región anal, que ella asociaba con patología hemorroidal. Niega fiebre, hematoquesia, y presentaba el examen físico un índice de masa corporal de 16, estaba francamente adelgazada, pesando 48 kilos. Al ingreso traía un laboratorio, además, con un hematocrito de 39, hemoglobina de 11, 10.000 glóbulos blancos, una ferremia de 44 y una PCR elevada de 11 miligramos por litro. Frente a este caso, lo que decidimos obviamente fue hacer un examen físico de la paciente. Se realizó la interconsulta con el servicio de gastroenterología para evaluar el estatus general de la paciente. Ellos también realizaron un test de sensibilidad a las tiopurinas, el cual tuvo un resultado favorable. Se realizaron serologías para hepatitis B, C y para TBC, todas con resultado negativo, y se solicitó una nueva videocolonoscopía. Al examen físico, a nivel abdominal no se evidenció ninguna masa palpable, y a la inspección anal, un orificio fistuloso en hora 2, con leve induración local y secreción purulenta, descartando la sospecha de patología hemorroidal que refería a la paciente. Y bueno, recordar que en los pacientes con enfermedad de Crohn hasta un 25% van a desarrollar fístulas en el seguimiento a largo plazo. Decidimos realizar la videocolonoscopía. En esta evidenciamos úlceras iliales que se extendían hasta ciego, con una estenosis a nivel ilial que pudo ser dilatada con balón, y lo más importante, el recto sin lesiones. Hasta ahora entonces lo que tenemos es una paciente con una fístula con un trayecto simple y el recto sano, con enfermedad ileocecal. En el momento tenía un índice de actividad de enfermedad perianal de 6, con un disconfort sin restricción, moderada secreción purulenta, una induración mínima, sin restricción en su actividad sexual, y bueno, era una sola fístula como mencionamos previamente. En el servicio lo que decidimos fue seguir las guías ECO para el diagnóstico de lo que es la enfermedad de Crohn perianal. Realizamos una resonancia de pelvis, que como sabemos debería ser el procedimiento inicial, es segura, no es invasiva, tiene una alta sensibilidad y especificidad, y me permite conocer la anatomía, el trayecto de las fístulas y descartar colecciones asociadas. También vamos a realizar un examen bajo anestesia, que es hoy en día algo estándar, siempre que sea realizado en manos de cirujanos experimentados, y podría haberse realizado, aunque en nuestro caso no lo hicimos, una ultrasonografía que realizada por expertos tendría un valor equivalente al de la resonancia. En la resonancia entonces lo que encontramos fue una fístula interefintérica con signos de actividad y una colección asociada de 10 milímetros de diámetro. Se calculaba en ese momento un índice de Van Aye de 11, les recuerdo rápidamente, el índice de Van Aye evalúa las características de la fístula en los pacientes con enfermedad de Crohn. Era un único trayecto, con una colección de más de 3 milímetros, hiperintensa en T1, hiperintensidad leve en T1 y moderada en T2, interefintérica sin compromiso de la pared rectal y con una extensión infraelevador. Realizamos también una enteroresonancia. Acá lo que podemos ver fue afectación iliocecal e ilial parcheada. El componente impresionaba a ser de características agudas, sin evidencia de patología crónica o fibrosis o estenosis asociadas a la enfermedad inflamatoria. Bueno, y finalmente, para hablar un poco del tratamiento, cómo tratamos a esta paciente, tener en cuenta que la etiología de las fístulas en la enfermedad de Crohn, más allá de que en algunos casos podría ser de etiología criptoglandular, suelen iniciarse más bien en úlceras, en lesiones ulceradas penetrantes en canal anal o en recto. Al ser una fisiopatología diferente, al ser lesiones más invasivas y más difíciles de tratar, lo que es muy relevante es el trabajo interdisciplinario. Vamos a iniciar con tratamiento antibiótico, colocar un sedal y drenar la colección, y vamos a hacer un tratamiento junto con el equipo de gastroenterología para optimizar el tratamiento dirigido a la enfermedad inflamatoria. Como dijimos, en primer lugar tenemos la antibiótico-terapia, indicamos ciprofloxacina y metronidazol durante 7 días, evidenciando una amplia mejoría sintomática, con disminución del dolor y de las molestias perianales, aunque con persistencia de las secreciones. Para este momento, el índice de Hervey-Bradshaw de este paciente era de 2, al inicio de la evaluación era de 10. Les recuerdo, es un score de severidad clínica, que evalúa, bueno, criterios clínicos subjetivos que evalúan el grado de severidad de la enfermedad. Colocamos el sedal y realizamos el drenaje de la colección. Acá también hicimos el examen bajo anestesia, no evidenciamos estenosis ni nuevos trayectos, y con el sedal ya la resolución sintomática fue casi completa, con un índice de Hervey-Bradshaw de 0. Y como mencioné previamente, junto con el equipo de gastroenterología se optimizó el tratamiento médico con anti-TNFs, infliximab, cada 3 semanas y tiopurinas hacia teoprina. La evolución de esta paciente fue muy favorable. Ya al mes del tratamiento médico y quirúrgico presentaba un ascenso del hematocrito con un descenso de la PCR, ya un valor que todavía no está dentro de los parámetros normales, pero se acerca de 4,2. Empezó a subir de peso con un índice de masa corporal de 18 y sus episodios de diarrea fueron disminuyendo a 4 o 5 episodios semanales. Y ya a los 3 meses el índice de Hervey-Bradshaw persistía siendo de 0, un hematocrito de 43, hemoglobina de 14, PCR dentro de los valores normales de 1,7 y un índice de masa corporal de 21, aislados episodios de diarrea. Decidimos realizar una videocolonoscopía control, logramos canular ilion distal, ya no se evidenciaba la estenosis y una amplia mejoría de las lesiones de las úlceras previamente mencionadas. En conclusión, bueno, importante tener en cuenta que todo este tratamiento se basa en lo que es el consenso de Toronto para la guía del manejo de la enfermedad, la enfermedad de Crohn fistulizante perianal. Tener en cuenta que esta enfermedad es un fenotipo frecuente, pero agresivo y de muy mal pronóstico, y siempre que haya signos o síntomas de actividad y sospecha de absceso es importante el tratamiento en equipo. Hacer el drenaje del absceso en el caso de que lo haya, colocar el sedal, y optimizar realizar el tratamiento antibiótico y siempre optimizar el tratamiento sistémico. Cuando el tratamiento tenga una respuesta adecuada, los pacientes van a persistir con este tratamiento dirigido a la enfermedad, pero hay hasta un 25% de los pacientes que no van a responder al tratamiento y que incluso pueden requerir ostomías o incluso protectomías por falta de respuesta a estos tratamientos. Es una forma de presentación que va a alterar significativamente la calidad de vida de estos pacientes, y al tener una etiología peculiar y una forma de presentación particular, es importante tenerla en cuenta, hacer el tratamiento específico y en un equipo multidisciplinario para ofrecerle a los pacientes las mejores opciones y mejorar la calidad de vida dentro de lo que sea posible. Y eso es todo. Muchas gracias.
Bueno, muy bien. ¿Me escuchan?
Sí, Doc.
Bien. Bueno, ¿hay alguna pregunta? ¿Hay alguien que quiera hacer alguna pregunta por ahí?
¿Puedo escuchar esto?
Bueno, si no hay ninguna pregunta, damos por finalizada la sesión. Muchas gracias, Sasha.
Muchas gracias, doctor.
Muy buena presentación.
Gracias.
Bueno, muchas gracias a todos.